Good afternoon and welcome to today's program titled Polypharmacy, What is it and what do we do about it? I'm Pamela Tabar, Editor-in-Chief of iAdvance Senior Care. Today's program is sponsored by Omnicare, a CVS health company. So thanks very much to our sponsor and to everyone in our audience for giving us your time and attention today. Before we get started with the program, I just want to take care of a few housekeeping details. First, to submit a question or a technical issue, please use the Q&A area below the slides at any time. You don't have to wait until the end of the program to submit a question. To download a copy of the presentation, please click the link in the Resources tab to the right of your slides. A special note about CE credits. In order to get your CE credit, you must watch the program all the way through the Q&A session at the end of the presentation. At the end, do not leave this web page. The site will automatically redirect you to your certificate. For those who are watching in a group, please download the group submission guide in the Resources tab and follow the instructions provided. And please note, CE credit is not available for the archived version of this webinar. It's only available for this live event today. Finally, join the conversation on Twitter by tweeting with the hashtag IASCLiveWebinar. And so at this time, it's my pleasure to introduce today's speaker, Sarah Lawrence. Sarah is the Assistant Professor of Clinical and Administrative Sciences and Director of the Pharmacy Technician Program at Sullivan University College of Pharmacy in Louisville, Kentucky. Her long-term care experience includes 3 years with Pharmerica, where she was manager of formulary and therapeutics. In that role, she oversaw per diem formulary management, pharmacy and therapeutics committees, clinical initiatives, and both internal and external educational programs, including Pharmerica's Clinical Geriatric Symposium. Dr. Lawrence is also a board-certified geriatric pharmacist. So, Sarah, thank you so much for taking the time to speak with us today. And with that, our audience is yours.
Thank you, Pamela, and thank you to everyone for taking the time to attend this afternoon. I have no relevant disclosures of conflict of interest as it pertains to this presentation. And this slide just has a little bit more about me. One neat factoid is that our arrangement here at the College of Pharmacy at Sullivan University, where we have faculty members who teach both Doctor of Pharmacy students and pharmacy technician students, sometimes in the same classes, is pretty unique. We may be one of the only colleges of pharmacy in the U.S. doing that, and so I'm very proud to be involved in that effort. And now for our learning objectives. My goal for you, the audience, at the end of this presentation is that you will be able to define polypharmacy and list risk factors that can contribute to it in older adults, discuss the additional risks of polypharmacy that are experienced by adults with dementia, and apply best practices for medication management in memory care patients. We would have to begin our discussion of medication in older adults with a discussion of the age-related physiologic changes that come with aging. And I've organized this slide around 3 separate systems, but I will talk about a few others as well. First of all, the liver. The liver is much less efficient with age. The CYP or CYP metabolism through the enzymatic metabolism of the liver is greatly reduced in older adults, up to 40% slower. The liver itself is smaller, blood flow is reduced, and overall it's just not as efficient. The liver is the primary site of the production of vitamin K dependent clotting factors. That's reduced in advanced age. So that leads to an increase in the risk of bruising and bleeding. And albumin production also declines as we get older. That is significant in that albumin binds certain drugs in the bloodstream, and only the unbound portion of drug in the blood is active. So with certain medications, when they're administered, some of them are going to be bound to albumin and inactive. When we have less albumin in the bloodstream, the portion of free drug increases, as does the therapeutic effect of that drug. So we can actually get some sort of an over-therapeutic situation on certain medications because of that liver function. The kidneys also are less efficient as we age. We see a decrease in creatinine clearance and an overall decline in GFR, glomerular filtration rate. And that GFR is the basis for renal adjustment of certain medications. We do that because as we age, we are at higher risk of kidney injury from medication. Muscle and bone also have age-related decline. We see an overall decrease in muscle mass that can interfere with strength and gait, and we see a decline in the ability to exercise. We also, because of that loss of muscle mass, can experience some decreased insulin sensitivity, potentially increasing hyperglycemia in older adults. And then bone loss, age-related bone loss, is implicated in the risk of fracture, which is tied to falls, something we'll get to a little later in the presentation. But beyond the liver, the kidneys, and the bone and muscle, the immune system is less efficient. Older adults are more vulnerable to infection. The urinary tract exhibits dysfunction overall, something we're going to discuss as well. And there are age-related declines in pulmonary and cardiovascular function. I'd like to start off by sharing a patient case, and this is used with permission from meded101.com. This is a free clinical pharmacy blog. It's available for anyone. These cases are published about weekly, a couple times a week. So, to introduce our patient, she is a 79-year-old female, and she presents with increasing confusion. Now, we don't know what her confusion level was at baseline, and we don't have her diagnoses, but we know that the confusion has increased. We can intuit some of her diagnoses from this med list, but we don't have them in front of us. And as you can see, this is clearly a polypharmacy patient. Looks like about 17 medications on board, a mix of scheduled and PRN. And I would like for you to just keep this case in mind as we go through our talk. We will revisit it at the end and maybe think about where we might start with addressing this patient and her confusion. To address our first learning objective, we are trying to define polypharmacy, and the word itself has its roots in the Greek language, with poly meaning more than one, and pharmacy coming from pharmakon, which means drug. So literally, the definition of polypharmacy is the use of more than one drug. Practically speaking, we don't have a standard definition that's agreed upon by clinicians. The meaning has evolved over time, means different things to different people, and there's just clearly no consensus on how many is too many. One article that I looked at in trying to define polypharmacy, this was published in the BMJ, looked at different types of polypharmacy. And remember, I said that the meaning has evolved over time, means different things to different people. So when you hear the term polypharmacy, the speaker may be referring to the use of multiple drugs. They could mean excessive use of drugs, either too many or excessive doses of all medications, unnecessary medications, medications that are unindicated, and I've put the last one in quotes, or quote-unquote appropriate polypharmacy, and I'm going to discuss what we mean by that. Clearly, polypharmacy is not a term that is used in a positive way. I don't think anyone has good connotations when they hear that term. But there are, of course, cases where the use of multiple drugs is indicated and appropriate. And this is something that we know is very common in older adults. They frequently have multiple disease states, necessitating the use of multiple medications to manage. We have evidence-based guidelines that dictate appropriate treatment, usually for a single disease. We have the ADA, we have the J&C, we have the American Cardiologists, the GOLD guidelines for COPD, but each of those dictates treatment for a single disease state, but doesn't always talk about comorbidities or other diseases that the patient could have. So for instance, a patient with diabetes could be on up to 3 oral agents or up to 2 insulins or various combination of oral and insulin. Heart failure, the patient typically will be managed on 3 or more medications, especially in advanced stages. And then patients with COPD often have multiple inhaled medications that are indicated to manage that condition. So those guidelines dictate that treatment, and basically we're going to have a polypharmacy situation when a patient has more than one disease state. But what is not always covered in the guidelines is how the treatment for one disease state could impact the patient's other disease states. For example, there are diabetes medications that can worsen heart failure. Corticosteroids used for COPD could complicate diabetes. So even when polypharmacy is appropriate, when the use of multiple medications is appropriate, risks are still present. And those risks include drug interactions, drug-disease interactions, and I've just described a few of those, and adverse reactions. So even in a situation of appropriate use of multiple medications in older adults, monitoring and optimization are critical to avoid exposing the patient to unnecessary risks. And I know that this slide is impossible to see, so I'm going to get to the next one in a second and explain what this is. But the study here by Mayer and his group attempted to define polypharmacy in different settings. And that made me wonder, does the setting matter? Is polypharmacy in the nursing home the same as polypharmacy in the hospital or in the community? And so this particular study attempts to address that question. And here on slide 16, I'm summarizing what was on the other chart in a way that I think is easier to read. What the researchers found was that in ambulatory care settings, 5 and above was the typical cutoff when identifying polypharmacy in that population. Now, 5 drugs is not a lot, is it? You can easily imagine how an older ambulatory care patient or even a younger patient could need 5 medications on a daily basis. That was the typical number that they identified. And the medications in that setting were those that you would expect to manage chronic disease states like blood pressure and diabetes. In the hospital, and I should disclose that there were a lot fewer studies done on polypharmacy in the hospital than in our other 2 settings. 5 was also sort of the generally agreed upon cut point, with the medications being those that were more commonly used for acute indications, GI prophylaxis, antithrombotics, and then some BP meds. In our nursing home setting, the cutoff for identification of polypharmacy is higher, at 9. And remember, this number is calculated by reviewing other studies of polypharmacy in that setting. And in 9 even seems low to me. Our patient that we had a couple of slides back was nearly doubling that number. But this is what the study found. And the common classes of medications implicated in polypharmacy or identified in polypharmacy in nursing homes draw from both the chronic and acute indications, so some from the hospital, some from the ambulatory care setting, as we would expect. And most of these studies, perhaps all except for a few, focus on the use of multiple drugs. There are far fewer out there that look at the use of unnecessary drugs, so that might be an area for future study. So, regardless of setting, I think that we can define polypharmacy as the use of multiple medications in a single patient, and this is an and/or list. The inappropriate use of medication and/or the use of unnecessary medication. And in all situations, polypharmacy is a risk factor for adverse drug reactions, disability, and death. The clinical consequences of polypharmacy are fairly substantial. In terms of cost, polypharmacy is associated with an increased risk of outpatient provider visits and hospitalization, leading to, and this is one study, a 30% increase in medical cost. Adverse drug reactions are higher in patients who experience polypharmacy. In fact, in nursing home residents with 9 or more medications, the rate of adverse drug reaction is twice as high than it is in patients with fewer meds. Drug interactions are also increased. When a patient has between 5 and 9 medications, the risk or the probability of a drug interaction is about 50%. If we increase that to 20 or more medications, so close to what our patient a few slides back had, the probability of a drug interaction increases to 100%. More medications, greater risk for drug interactions. Non-adherence is another clinical consequence of polypharmacy, and this is an issue with both community and institutionalized patients. There are a variety of reasons for non-adherence. Community-bound patients may simply not be able to comply with their complicated medication regimen. And even institutionalized patients who are getting their medications from a nurse or from another healthcare provider may not be willing to comply. And you may see refused med passes and non-adherence in that setting as well. Polypharmacy is also associated with a decline in functional status, and this is particularly true in women. In women, polypharmacy is strongly associated with diminished capacity to perform those activities of daily living. It's also associated with cognitive impairment, and this is a problem in patients with existing dementia and then patients who are at risk for delirium as well. It increases the risk of delirium. And then urinary incontinence, nutritional problems, and falls. I'm going to spend a little bit more time talking about each of those. They are what we would call geriatric syndromes that are potential consequences of polypharmacy. And a geriatric syndrome is a group of symptoms that occur typically in an older adult, but that don't make up a discrete disease state. They're not a new disease, but they are a series of symptoms that are experienced by older adults, and they're often related to medication and to those risks of the age-related changes that we talked about a little bit earlier. So here I'm showing you a cycle. This is one of the risks of polypharmacy is that it perpetuates itself. So if we start in the upper right-hand corner, we have a patient with, let's say, 15 medications, a complicated medication regimen, who for whatever reason doesn't adhere to that regimen, doesn't take their medication, doesn't take it on time, doesn't take it in sufficient quantity, adherence problems. That contributes to interference with the treatment process. And that could be exacerbation of existing disease, or it could be creation of an entirely new problem that resulted from the earlier adherence problems. Either way, the patient either gets worse or develops a new symptom, which drives the need for additional medication. We add something else on, the regimen is even more complicated, even more difficult to adhere to, and the cycle continues. So the idea, what we're talking about today, is how to break that cycle. And this is a complicated problem. There are many contributing factors to polypharmacy. I've already spent time talking about multiple disease states and how that contributes to the need for multiple medications in a single patient. Another contributing factor is the use of multiple prescribers. And I think that this is more of an issue in the ambulatory care setting, but can be an issue in the institutionalized population as well. But I'm drawing from my experience. I spent a year after my residency working as an independent consultant pharmacist, reviewing retiree medication profiles for the Kentucky retirement system. And what I found was that most patients were seeing more than one doctor, usually the primary care physician and then a specialist or two, and there was a lot of duplication that came from that. Maybe an ACE inhibitor from the PCP and one from the nephrologist. Different insulins from PCP and endocrine. Or perhaps the patient went to an urgent care or the emergency room, picked up another script that didn't necessarily go well with what they were being prescribed from their regular care providers. So that kind of discoordination in prescribing contributes to polypharmacy. Another issue is self-medication. And here I'm talking about over-the-counter products and herbals and supplements. These are things that any of us, any patient, can go and purchase. We can head down to the grocery store, the pharmacy. We can order these from Amazon. And the elderly in general are over-consumers of OTC and herbal products as compared to the general population. And these are not benign products. There are plenty of drug interactions, drug disease interactions, and adverse reactions to be had from the use of over-the-counter and herbal products. For instance, some of the top supplements in the elderly include, and I call these the G herbs: garlic, ginkgo, ginger, and ginseng. All of these are used for various indications, increase bleeding risk, something we're already worried about in our senior population. What if a patient on warfarin adds one of these herbs? It's going to potentiate the effects of that warfarin. Another common supplement is St. John's wort. And St. John's wort should be considered a high-risk drug supplement or a high-risk supplement. It has many drug interactions that are mediated by that hepatic enzyme system I talked about earlier. Typically, St. John's wort decreases drug levels and, of course, then drug effectiveness. It should also be used with caution in any patient who's taking another drug that increases serotonin in the body. So antidepressants and other psychoactive drugs can interact and potentiate with St. John's wort and put patients at risk for an adverse reaction. Another contributing factor is medication hoarding. What I'm talking about here is perhaps the patient had surgery, didn't use all of their pain medication, perhaps they had an infection, they didn't finish all of their antibiotic, and they've kept it, they're holding on to it, and at a future time they take it out and use it to self-treat for something that's going on with them at that time rather than going to their provider. So the provider doesn't know that the patient's using that medication at that time, There's no one looking to say, is this appropriate with what the patient is currently taking? And it puts the patient at risk. Patients are also at risk during any transition of care. And I think that we all spend a lot of time thinking about transitions of care. My mother had a hospitalization earlier this year. I saw some of the problems that can occur at those time periods. So let's say a patient is admitted to the hospital. We don't get a good med list. We don't get a correct med list from the patient. It's hard to know what they're supposed to be taking. They are prescribed a different set of medications in the hospital. Perhaps hospital formulary requires the use of a different statin or a different blood pressure medication, so something else gets added on. They're discharged from the hospital with a different list of medications. Sometimes the information at discharge is not good in terms of what about other medications? What are they supposed to continue on their own in the community, and what should they discontinue? And then at the discharge to the nursing home, it's the same issue. When I was working on the corporate clinical team at my last employer, we looked at hospital discharge meds and targeted those for review and elimination. So asking, does this patient actually need GI prophylaxis now that they're in the nursing home setting? Can we drop that off? Is the patient still having problems with nausea and vomiting? Or can we discontinue that on Dancitron? So there's lots of work to be done at those periods of transition to make sure that patients are taking what they need to take, aren't taking too much, and that all conditions are adequately treated. I've already mentioned drug interactions and what the risks of those are and how those risks increase as the number of medications increases. Remember, at 20 medications, we have a 100% chance that a patient will have an adverse reaction. But even 50% at 9 medications are pretty good odds of interactions. So from a publication that some of you all may be familiar with, this is a reference put together by MedPass and the American Society of Consultant Pharmacists. I have summarized the top 10 dangerous drug interactions in long-term care, and you're probably noticing what I did, that 5 of them are related to warfarin. Warfarin interacts with, I hesitate to say everything, so we'll go with almost everything. And these drug interactions are particularly dangerous. Warfarin and NSAIDs increase the risk of bleeding, particularly GI bleeding, because NSAIDs disrupt the mucosa of the gastrointestinal tract. So if a bleed occurs in the GI tract, warfarin is going to make that worse. And then antibiotics and warfarin are another area of particular concern. Most antibiotics increase the action of warfarin. They make it work better and increase the bleeding risk. Then ACE inhibitors increase potassium, so when they are given with potassium supplements or with potassium-sparing diuretics, you can get a situation of hyperkalemia leading to EKG changes. And our next slide summarizes what I've just shown you, and I know, well, and it includes other drug interactions as well. This is from the American Geriatric Society, Beers criteria, which aims to identify potentially inappropriate medications in elderly patients. And I know that this is hard to see. I wanted to include it. You can go to the Beers criteria. It's available online, and pull up a bigger copy of this. Most of the drug interactions from my previous slide are included on this list, plus others. And these are all combinations that should be avoided in older adults. I said we would talk about geriatric syndromes, and now we're going to begin doing so. And I've started with falls. I think that falls are something that all of us who care for older adult patients spend a lot of time thinking about. They're the leading cause of injury among older adults in the United States. They're responsible for untold morbidity and mortality and increased cost from hospitalization, emergency room visits. 27,000 deaths in 2014 were attributed to falls. And we probably all can think of a patient or a family member or someone that we know who was in pretty good health, functionally strong, experienced a fall that began their decline into disability and often contributed to an untimely death. I can think of several examples of that. So falls are something that we really want to prevent. And medications contribute to the risk of falling. And institutionalized patients are at even higher risk of falling than those who reside in the community. One study indicated that up to 3/4 of the adults living in nursing homes fall every year, with non-ambulatory patients having the highest risk. Even fear of falling can be debilitating for a patient. If a patient fears falling, that may lead him or her to stay in their room. They may not want to go to the dining room. They may not want to go down to the day room for activities. They're going to isolate themselves in their room. This can contribute to depression. It can contribute to loss of function and ultimately set them up for even greater decline. And I'm sure everyone knows that works in long-term care that facilities can be cited for failing to adequately address fall risk, and that's F323. I mentioned the medications. I could spend an entire hour talking about medication that can increase the risk of falling. We developed a reference for that in my previous job. It was about 8 pages long. Many classes of medications can increase the risk of falling. So what I'm showing you today is just a summary. It is by no means an exhaustive list. Among those classes of medications that can increase fall risk, we have anticholinergics, so medications for bladder control, diphenhydramine, anything with anticholinergic effect, blood pressure medications, alcohol, often overlooked, something that should definitely be discussed with community-dwelling elderly. And then the Beers criteria from the American Geriatric Society has a list of specific medications that should be avoided in patients who are at risk for falling. And those include anticonvulsants, antipsychotics, benzodiazepines like lorazepam, alprazolam, non-benzodiazepine hypnotics, and I want you to remember these as your Z drugs. Your sleep medications like Zolpidem. The brand names are Ambien, Lunesta, and Sonata. Antidepressants, and opioids. Now remember, these increase the risk of fall in all elderly patients, but they should specifically be avoided, if possible, in patients who have a history of fall or fracture. So it's used with caution in all older patients, avoid in those with a history of fall and fracture. And here on slide 26, I'm showing you different classes of medications and how they can contribute to the risk of falls. There are different medication side effects that increase fall risk. And I won't read this to you, but I want to highlight a few things that I think are interesting. I talked about those Z drugs. So let's imagine a patient takes Lunesta at bedtime. It's a hypnotic to help the patient sleep through the night. The patient either wakes up on their own in the middle of the night, maybe wakes up, needs to go to the restroom, but is pretty drowsy. Maybe it's been a few hours since she took that Lunesta. So she's trying to get out of bed to go to the restroom. She's drowsy. She may be a little confused. Patient has a fall. We've also, and I'll talk about this a little bit more, but we've also contributed to functional incontinence there, haven't we? Because the patient can't make it to the restroom and has an accident. Then antihistamines can cause blurred vision. And that blurred vision, that reduced visual acuity, can put the patient at increased risk of falling, especially if the path that the patient has to walk is littered. I'm imagining in an ambulatory care setting or in a patient home, newspapers and throw rugs, maybe a cat or two on the floor. The patient's blurred vision leads to tripping and falling. So there are different ways that medications can contribute to fall risk. And again, this list of medication classes is not exhaustive. There are many others. These are pulled from another MedPass ASCP publication that you can use to reference those medications. So we have another patient case, and I think we're going to have a question after this one. Here we have an 86-year-old male. He is having a difficult time with weakness and with falling. His family tells you that he's a little bit too sleepy at times, and he does have some mild cognition problems. His latest vital signs were BP of 102/76, which dropped to 72/54 when an orthostatic reading was checked, so when he went from a prone to an upright position. The patient's pulse is 62. Look through his medication list quickly. There's quite a bit on there. Looks like 8 or 9 medications. So based on the med list and then the clinical scenario, which of these medications is most likely to be contributing to the patient's risk for falling? Is it aspirin? Is it amlodipine, famotidine, or latanoprost? And in this situation, I think the medication that we would look at as the likely suspect is amlodipine, because this patient's blood pressure was 102/76, which is well within goal for a patient of advanced age. It's actually below what we would expect to see. So it may be that this patient doesn't need to take blood pressure medication anymore. And we would want to reevaluate that, because that drop in BP with the resultant dizziness could cause the patient to fall. The next geriatric syndrome I'd like to discuss is urinary incontinence. And this is another syndrome that affects high numbers of older adults, more than half of women in the community, more than a quarter of men. It's actually often underreported, so these numbers may not even be accurate. And it's much higher in the institutionalized older adult population, and is in fact a major factor in nursing home placement. As with falls, urinary incontinence can be traced to many different classes of medication. You probably are all aware there are different types of urinary incontinence. There's urge incontinence, which is the gotta go. There's stress incontinence, which is associated with coughing or with exercise. And different medications have different ways that they can contribute to incontinence. For example, ACE inhibitors can cause a cough that can increase stress incontinence. And urinary incontinence is addressed in the State Operations Manual in F315. The Beers criteria has pretty strong language about the use of medication to treat urinary incontinence. My previous slide showed you medications that can cause it. And often the result of that is thinking, I'm going to add on a medication to treat the incontinence, but most of the medications in that class are high risk for older adults because of their anticholinergic properties, so they can increase fall risk. And everything on this list should be used in caution in older adults and should be avoided in patients who have dementia or those who are at high risk of delirium. Polypharmacy is also associated with nutritional issues. Patients may have reduced interest in eating, whether that's because it's a primary drug side effect or patients are tired and lethargic from their medications and don't feel like going to the dining room. They may have sensory changes that reduce the pleasure and interest in eating. And community dwelling elderly who have functional decline may find that they are no longer able to prepare their own meals or to prepare appropriate meals for themselves. In fact, one study found that polypharmacy was associated with a reduced intake of fiber, fat-soluble, and B vitamins, and increased intake of cholesterol, glucose, and sodium, which tells me that patients weren't able to cook those nutritious meals anymore and were relying on a lot of processed food. The other mechanism here is drug-induced nutrient depletion, and I think we're getting short on time, so I'm just going to go past this, but know that this is something that you do need to monitor, and at times supplementation may be appropriate. This is addressed in F325. The polypharmacy in dementia was our second learning objective. We know that patients with dementia take more medications than those without dementia, and they are at increased risk for complications from polypharmacy. Because they can't follow directions, that loss of executive function makes adherence an issue. They're at increased risk of adverse drug reactions and difficulty in identifying and reporting adverse drug reactions because of the cognitive decline. I have included this slide only to show you that some of the common medications for dementia may actually contribute to some of the adverse effects and geriatric syndromes that we've discussed. For example, cholinesterase inhibitors, drugs like Aricept, can decrease the appetite, can increase falls risk, and cause urinary obstruction. Now, this is not to say that these drugs are inappropriate to use in patients with dementia. They absolutely are, but it just highlights the need for monitoring of the medication regimen. The Beers criteria speaks to medications that we should avoid in patients with dementia or cognitive impairment. We've also already talked about a couple of these in our other discussions of geriatric syndromes, but we add here H2 receptor antagonists, which I think is notable, Zantac, Pepcid, Tagamet. These are implicated in worsening cognitive impairment. And I want to mention antipsychotics here. I think everyone who works in the long-term care industry is familiar with the issues with prescribing antipsychotics for patients who have dementia. We know that they should not be prescribed for those behavioral problems unless our non-pharmacologic and safer drug options have been exhausted and the patient is a threat to self or others. And these medications have a black box warning or boxed warning because they increase the chance of stroke and death in patients with dementia. The next slide just shows you some of those anticholinergic drugs that can increase the risk of polypharmacy in patients in dementia. And I'm going to spend the last 5 minutes talking about how we can reduce risk. For our ambulatory patients, we want to make sure that they keep an accurate list of medications, who prescribed them, pharmacy name and contact information, and that they know how to use their medications and make use of memory aids as appropriate. I'm showing you here a free printable medication management chart. You can get that from the internet. There are a variety of pill boxes, some low-tech like I just showed you, some more high-tech like the ones that are on the screen now, that can be used to help patients adhere to their regimens. For institutionalized patients, Consistent assessment and reassessment of each medication with discontinuation as appropriate is critical. F329 mandates that gradual dose reduction for patients who are using psychoactive medications. I've listed the classes. We want to make sure that we're using evidence-based guidelines to evaluate those potentially inappropriate medications. I talked a little bit about the Beers criteria, or substantially about the Beers criteria already. We also have the stop-start criteria, which gives not only guidance about medications to avoid, but also medications to potentially use. START stands for Screening Tool to Alert Doctors to Right Treatments. Then we also have the ARMOR criteria, which is another system of evaluating and optimizing medication regimens. ARMOR stands for Assess, Review, Minimize, Optimize, and Reassess. These are all available online. We want to simplify the patient's regimen, de-escalate therapy for chronic conditions where we can. Think of our patient from the case who probably doesn't need his amlodipine anymore. We do have less aggressive goals for diabetes and blood pressure at the end or at advanced age, so we can often scale back therapy. Think about discontinuation of certain medications in patients with limited life expectancy. Look for non-pharmacologic interventions where we can, particularly in conditions like insomnia or behavior disorders or urinary incontinence. We want to maximize the non-pharmacologic interventions and not start a new drug without really thinking it through. And then for new onset symptoms, we need to consider whether the drug or condition that the patient is experiencing could be an adverse reaction or drug-induced. And the steps that I'm going to show you on slide 38, this is an algorithm from the Canadian Health System. Their first step in optimizing senior medication use is to ask, can this be caused by a drug, before proceeding with a new therapy. Beyond that, they seek to determine which drugs are still providing benefit, and then prioritize drugs for tapering and stopping, and develop a plan, coordinate, communicate with the prescriber and patient, and simplify to reduce the pill burden. Back to our case, and I apologize we don't have very much time. There's a lot going on here. My first thought is the patient really taking all of these PRN pain medications? How much, how often, what's going on with the patient's pain level? Beyond that, the patient's dose of valproic acid is pretty good for an older adult, so I would want to know, is this new? Has this recently been increased? And then we have two anticholinergics on board here, the valproic acid and the Benadryl and the Tylenol PM. Those could also, not the valproic acid, the tolterodine, which is Detrol, and the Tylenol PM are both anticholinergic and could be causing that worsening confusion. And that's just my initial thoughts on this med list. There's quite a bit that we could do here. So I won't read my conclusion because I think we are near the end of my allotted time. But we will, I believe, have time at the end for some questions. In the meantime, I've given you my contact information. Feel free to reach out to me with questions that you have after the presentation. And at this time, I am going to thank you for your attention and turn the presentation back to our moderator, Pamela.
Thank you, Sarah. I do think we will have time for a few questions, but as we just start to wrap up this discussion, I'd like to take a moment to introduce Alan Lefkowitz, who's a Senior Manager for Clinical Education in Long-Term Care for Omnicare, a CVS health company, and our sponsor for today's program. Alan has served in the long-term care industry for more than 21 years and has been a board-certified geriatric pharmacist since 2006 and a fellow of the American Society of Consultant Pharmacists since 2007. In addition to his responsibilities as a consultant pharmacist, Dr. Lefkowitz is a member of CVS Health's Geriatric Center of Clinical Excellence and works on the development of OmniCare's clinical education programs for pharmacists and nursing home customers. So, Alan, I'd just like to bring you into the discussion at this point and ask if you could just take a few minutes to share some of your own thoughts and perspectives with us.
Sure. Thank you, Pamela. I'm grateful for this opportunity to briefly reinforce what Dr. Lawrence has already shared, as well as to discuss some additional considerations around polypharmacy. As those who are caring for seniors, we have a duty to make sure that they're protected in a variety of ways, but that includes avoiding harm related to our attempts to treat them with various medications. Without question, polypharmacy implies the individual patient is being exposed to unnecessary or potentially harmful medications. Thankfully, much of what we consider polypharmacy is preventable. But I think our need to be concerned about polypharmacy is well captured by this August 2016 Washington Post headline on the right side of my slide, which refers to America's other drug problem. As the acuity of those we serve continues to rise, the risk of polypharmacy also increases. Dr. Lawrence shared earlier, there's not one universally accepted definition of polypharmacy. In fact, about 10 years ago, researchers looking at polypharmacy, they put a spotlight on this reality when they found at least 24 different definitions within the medical literature. So when someone's speaking with you about polypharmacy, be sure that up front you get their definition before you go too far into the discussion. Even while I was preparing for this session, I saw a new term I hadn't seen before that may start to be used more often. That's hyperpolypharmacy. Those authors defined hyperpolypharmacy as taking 10 or more medications. Yet, as Dr. Lawrence mentioned earlier, the average nursing home resident is often taking 9 or 10 or more medications each day. So that definition of hyperpolypharmacy doesn't really help us much. I state at the bottom of this slide, for some individuals, one medication may be too much. And for others, 15 medications may not be enough. So this isn't a numbers game. As I go on to the next slide, we're moving away from numbers, and rather we're going to the pitfalls of polypharmacy. Polypharmacy must never be glossed over. If we distill down the 24 definitions of polypharmacy, 3 areas of focus rise to the top, those being overuse, underuse, and misuse. Some are surprised when you discuss underuse in the context of polypharmacy, but quite often, as the drug profile grows, it becomes easy to miss the forest for all of the trees. But whether we're talking about too much or too little of a good thing, or using the wrong drug or the right drug the wrong way, polypharmacy has several known consequences, which are shown here on the right. And certainly none of these are desirable, but in our practice, of course, we're looking to minimize the worsening of frailty, falls and fractures, and cognitive impairment. We also know that in healthcare, we're continually weighing the benefits versus the risks, but we need to consider the individual more than we consider the clinical practice guidelines. An over-reliance on those guidelines, especially in those with multiple disease states, or failure to take into account someone's aging, the effect on their kidney function perhaps, or not really individualizing our approach to someone's care. Those are all recipes for polypharmacy. But what I want to focus here on this slide is the right side. As we look at this, utilizing multiple drugs that increase the risk of bleeding or that decrease blood sugar or decrease blood pressure, all of those are reasons that we need to be aware of polypharmacy. But when we zoom in on our residents with dementia, something that I don't think we give enough playtime to is the discussion of anticholinergic burden, which Dr. Lawrence also alluded to. A high anticholinergic burden not only counteracts the drugs we commonly use in treating dementia, but they also contribute to increased confusion and impaired cognition. So a pharmacist's help here can really help you identify where these burdens can perhaps be eliminated. All of our efforts should have the goal, as stated at the bottom of this slide, to provide the right number of medications that lead to the best possible outcomes. And then as I wrap up, I want to conclude with just some additional ideas and reminders for addressing polypharmacy. We've said it before, but we have to watch for age-related changes, such as the declining kidney function, so that we can adjust drug doses. Secondly, we need to make sure that at each and every transition of care and in an individual's health journey, that a thorough medication reconciliation is performed. Often this is the best time to identify and intervene with polypharmacy, but just having a complete and organized list of medications is one place that we can really do a lot to combat polypharmacy. Likewise, everybody involved in senior care needs to be aware and on the lookout for adverse effects of the drugs. And whenever possible, we need to think about the use of other therapies, whether it's non-pharmacological or just an alternative medication that has a lower risk associated with it. And then the final idea I want to mention is continually and routinely assess and reassess each and every medication. Just because a medication was needed last month or last year doesn't automatically mean it's still needed today. Now, we hope that you found today's presentation informative and that this was idea generating, but what I hope everyone does hereafter, if you're not already doing so, is to make reducing polypharmacy an interdisciplinary priority. I want to thank you for your time, and at this point, I'm going to turn it back over to Pamela for a brief Q&A session.
Okay, thanks so much, Alan. And thank you, Sarah, again for such an informative presentation. We've had quite a few questions come in from the audience. I just want to remind everyone, if you have a question, go ahead and use that Q&A button and submit it now. You don't have to wait. One question that came in is Sarah, I guess this is for you. Is there a standardized evaluation somewhere out there that we can apply to new admissions to senior living?
I'm sorry, could you repeat the question? I apologize.
The question says, is there a standardized evaluation out there that can be applied to new admissions to senior living?
With the goal of reducing polypharmacy, I'll see what I think, and then I'll see what Alan, if he agrees. I think that an opportunity at new admission is to do that that evaluation that we've been talking about of the med list and checking it for appropriateness. The ARMOR criteria that I alluded to earlier in the presentation goes through a process of assessment it takes into account not only the medication list but the patient's clinical profile and functional status, and then it also tries to balance that with evidence-based guidelines. It also takes into account the age-related changes. So that's one tool that's available, and I wonder if Alan has anything he'd like to add to that.
Yeah, I would agree that ARMOR is good. I think the simplest approach is when you have a list of medications on a new admission, make sure there's an actual diagnosis from a prescriber on each and every medication. Don't just guess as to what the med might be used for. Make sure that there is a good, valid reason why they're using each drug.
Okay, very quickly, how do we involve direct care staff in helping us watch for adverse drug events? They're the ones who are there. They see very subtle changes in condition and function. Any thoughts on that?
I would say document everything and communicate as often as you can with the other caregivers and staff. I think it's that simple, that we're promoting an environment where they talk to one another.
Okay. I've just gotten the note that this is all the time we have left for Q&As. Thank you again, Sarah and Alan. We appreciate your time and your expertise. I just have a few final comments regarding the CE credits. Don't leave this page. Stay here. continue to stay on the platform and you'll be automatically redirected to your program certificate at the conclusion of the presentation. For those watching in a group, just a reminder, please download the group submission guide in the Resources tab and follow the instructions provided. Please note again that the CE credit is not available for the archived version. It's only available for the live event on March 23. So thank you, Sarah and Alan, once again for an excellent presentation. I'd like to say thank you again to our sponsor, Omnicare, for making today's program possible. And thank you to everyone in our audience for participating today. And we hope you'll join us in the future for another iAsk webinar. This concludes today's presentation.